Hi, and welcome to the Vet Dental Show. We have this month Dr. Victoria Lukasik, who is boarded in anesthesia, who has done a course for us that is about anesthetic safety in veterinary dentistry. And we'll be taking segments from this course for the podcast for the next month. So I know you're going to enjoy this. Super impactful. It'll probably change the way you practice anesthesia during your dentistry procedures. And at the end of each episode, we'll have a special link for you with a promo code where you can get this course and our other dentistry courses at a huge discount for this month. Hope you enjoy.
Hello, everyone, and thank you so much for joining me on this anesthesia journey. The first thing that we're going to talk about is how to put together a balanced anesthetic protocol. And when we talk about balancing anesthetic protocols, most of the time what we're talking about is drug protocols. But that balancing issue now has gone beyond what are we going to use for pre-meds, what are we going to use for induction, how much are we going to give. Hopefully induction is always to effect, but we have to calculate out some place to start. What we're going to mostly concentrate on is how to create a complete anesthetic plan and how to balance all of the parts of that together to create seamless care and the best care that we can for each patient as an individual. So we're going to start talking about anesthetic planning, and there's a lot that goes into planning for an individual patient. We have to actually know the patient, and that's on paper. What's their lab work like? What's their history like? Is there anything that the client has added to our knowledge, whether they've kept glucose curve testing for us, and I know clients can write down a lot of things that are really crazy and give us more information than what we want, but that on paper is usually what we get before we see a patient. And then we meet them in person. What's their personality like? Are they timid? Are they anxious? Are they fearful? And of course, if they have comorbidities, are they a cardiac patient? Or are they a renal patient? Or do they have liver compromise? Are they really large? Are they really small? Do they have a lot of body fat? And age is not a comorbidity. Age is a part of the continuing spectrum of the lifespan. However, we need to take that into consideration also when we're planning. We need to think about appropriate fasting instructions. Should we provide any type of gastric protection? Do we prescribe an antacid for our patient? What is their medication schedule like? Are they on any medications? Should they take them that morning? Should we withhold supplements that morning? What kind of supportive care are we going to need? And what's the clinic environment going to be like when that patient arrives? Then we can think about exactly what drugs we might need and what doses of those drugs. There's no good anesthetic drugs and there's no bad anesthetic drugs. They all are anesthetic drugs. It's the anesthetist that makes them good or bad, safe or unsafe. And then, of course, we need to put together a monitoring plan and a recovery plan, because there are some patients where we want to provide a full complement of monitoring to and additional types of monitoring like electrolytes or glucose. So let's talk about fasting first. And the fasting rules are actually changing based on objective data. And the American Animal Hospital Association published anesthetic guidelines for dogs and cats back in 2011. Now, that was a fair bit ago, considering that we've been doing the same thing rote over and over again for decades. No food, no water, long fasting times. But what we've found is that those fasting times are not necessarily in the best interest of our patient. Objective data has given us the opportunity to change fasting so that our patients are treated more appropriately as dogs and cats. They said adequate fasting is 4 to 6 hours long for dogs and cats. And then the American Association of Feline Practitioners has come and published new anesthesia guidelines for cats in 2018, said that geriatric cats, now that's cats 12 years old and older, 10 years old and older, they should be fed a small meal of wet food. Now, they didn't say volume, they just said a small meal of wet food 3 to 4 hours prior to anesthesia. And this is important to know, that feeding in this time frame 4 to 6 hours before anesthesia, 3 to 4 hours before anesthesia, does not increase the incidence of gastroesophageal reflux. What it does do is stabilize blood glucose, gives patients an energy source for the day that they're going to go through, which is a relatively stressful day. But it also helps to limit the amount of really acidic refluxate that comes out when patients do reflux. And so when we're talking about gastroesophageal reflux, and this is a quote from the position statement that the American College of Veterinary Internal Medicine published last year on the use of antacids in dogs and cats. And this quote just says, gastroesophageal reflux during anesthesia is associated with 46 to 65% of cases of benign esophageal stricture in dogs. And it's the most common cause of high-grade esophagitis and stricture formation in dogs. And it's a very interesting piece of literature because we thought that longer fasting times, the more empty the stomach was, the less gastroesophageal reflux would occur. And we've learned now by objective data that's really not true, and we have new fasting instructions. The question becomes, what should we do in addition to fasting if we're concerned about reflux and scalding of the esophagus? So what's actually been recommended by that article is we use a proton pump inhibitor in the peri-anesthetic period, and then we can also decrease gastric emptying time by using cisapride, which seems to work a little better than metoclopramide, but metoclopramide is okay. And so the use of other antacids, there's no evidence that they actually work in dogs and cats. And so what the Internal Medicine College put together was a recommendation to use proton pump inhibitor, and that would be given the night before and the morning of the procedure, and then at arrival to the clinic to be given cisapride or metoclopramide 2 hours before anesthesia time. So let's talk about pre-anesthetic laboratory testing. There's been a hot debate on this. So once we've decided that we're going to fast the patient properly, we give those instructions to the owners, patient comes in the morning for a procedure, we either have laboratory testing that's already been done, or we'll do laboratory testing that morning. There's a lot of hot debate on what we actually do with pre-anesthetic laboratory values. Do we do anything? Do we change protocols? Do we postpone procedures? Do we do anything with that information? And the articles that have come out over time were very contradictory in their results. There were articles that said no one changes what they're going to do based on laboratory testing, so why bother to do it? And more recent articles have come out and said, no, we do change what we're going to do based on laboratory testing. We can all agree we should do the testing, but if the testing comes back with abnormalities in it, what do we do with the numbers? Let's not ignore those numbers. Let's actually act on them. That's the reason we ran it in the first place. So this is just a compilation of percentages of cases that were manipulated by pre-anesthetic laboratory testing. And these cases were given to board-certified anesthesiologists to review. And the anesthesiologists, if you look at how many cases out of the pool that they looked at, said, oh, we would cancel or postpone in 6% of cases, or we'd change fluid therapy, or we'd repeat laboratory testing or do expanded laboratory testing, or we would change the ASA status, or we would change our client communication. And then, of course, the biggest category was to avoid the nonsteroidal anti-inflammatories, because that's information about renal function and hydration status. And so we're using what this really told us, and this was published in 2018, what this article really told us is that, and I know it was anesthesiologists that looked at the records and made these determinations, but there's articles that are similar to this that came out not too long before this, and we're looking more at our laboratory work as being part of essential anesthetic planning. And we're acting on it more and more every year once we see the importance of those laboratory values, and that we get the tools necessary to be able to act on the values. So I just want to talk about Peaches just for a second. And Peaches is one of those old chihuahuas that comes into the clinic that has a tongue that's not quite pink. She has lots of pink bandaging on, and there's a pink sign in the background there to compare to. But her tongue is not quite pink, but it's not quite blue. It's that dark pink color. What's one of the first things that we might want to do with Peaches when she comes in and we do her physical exam? One is, if her tongue is not nice and pink, we should do a baseline pulse oximetry reading on her. And I can tell you it was in the mid-90s, so that was okay. She may be just compressing her tongue and making it a darker color than usual because of the compression on the lingual vessels. The other thing that was very interesting about Peaches, and you can see the bandage around her neck and you can see the bandage around her leg. When Peaches came into the clinic, her laboratory testing was normal. Her platelets were normal on her history. When she came into the clinic, we were going to draw her pre-anesthetic labs that morning. And what happened was we went to do a jugular blood draw, and the blood was actually pouring out of the jugular vein around the outside of the needle. And we did a really good job cleaning her up because there's no blood on her right now. I go, oh, that's not a good thing. So we couldn't really get a very good sample. And it was a relatively clean stick, but we couldn't get a very good sample from her because of the odd presentation of the blood coming out around the needle. And it was filling the tube a little bit. So I went to the other side of her neck, to the other jugular, said, all right, that might not have been the cleanest stick. Let's try again. Very clean stick on the other side, same thing, blood just pouring out around the needle. Now, is that a normal thing for us to see? It's not. Got a sample on her, ran the sample. Her platelets were normal. It's consistent with her previous labs, no problem with platelets. But she got big hematomas from both blood draw places. What are we going to do? I go, her labs are normal, but her presentation looks like she has a bleeding disorder of some type. She has no history of bleeding disorder. What's the next thing to do? Send off a clotting profile. Clotting profile was prolonged. PT, PTT, both prolonged. We had elected already to not pursue dental work in Peaches today because we were anticipating extractions, and with the odd presentation of the blood draw, we elected to look and see what the clotting profile or bleeding times would say. We didn't do a mucosal bleeding time on her, which we could have done. But Peaches is one of those patients where the owner takes a vitamin D supplement in the morning, and she takes hers and gives Peaches the exact same size vitamin D supplement every single morning. And she takes a vitamin E supplement, exact same size, gives Peaches the exact same size vitamin E supplement every morning. We look at those two things and go, is the vitamin D going to be a problem? Oh, certainly it can be. But what about the vitamin E? That will interfere with clotting at high doses. So what we have is a patient who is taking a very high dose of vitamin supplement now, who is not a candidate for surgery because of apparent bleeding disorder from it. So we take her off of it. She comes back a month later to get her dental work done. And what's the first thing we're going to do in our pre-anesthetic laboratory testing? I hope everyone's yelling, expand it, do a clotting profile, or do a mucosal bleeding time. Absolutely true. Go ahead and check those things. They're normal now, and we can move ahead with the profile. So this is part of getting to know your patient as an individual patient after they come into the clinic. If something looks odd on their physical exam, stop. Think about what you need to do to explore it further. It's okay to postpone a case because you're not quite sure about something in a patient's presentation, whether that's on paper with the laboratory values, or that's in your physical exam, or during some manipulation, something happened. And so what are we going to do after we get to know our patient on paper, and after we get to know our patient on physical exam, and after we get to know our patient in any way that we might need to? Expanded laboratory testing, electrocardiogram, echocardiogram, any number of things. We're going to start choosing drugs for the protocol. We've decided about fasting. We've decided about gastric protection. We've decided about arrival time at the clinic. We've decided about many things up until this point. And then we need to think about drugs. So what's the physical status of the patient? How sick are they? How well are they? What's their surface area and body fat? Are they big patients? Are they small patients? What's their temperament like? What equipment do we have in the practice to support them? What procedure are we anticipating? Now, I know during dentistry we go, oh, we have no idea what we're doing until we take the radiographs. And that's actually very true. But we should start thinking about pain, potential complications, any type of postoperative needs that we might have for a particular patient. What are we experienced with? How long is it going to take? How invasive is this going to be? And then, of course, the anesthetist. Now, the difference between the anesthetist and the anesthesiologist is the anesthetist can be anyone. The anesthetist is the person who is administering the anesthetic drugs. And that's the person who's injecting them IV, who is changing the vaporizer dial settings, the person who is monitoring. That's the anesthetist. That's their job. Anesthesiologist did a residency and took a giant test, and they had to pass that test. And that certifies them as an anesthesiologist. So anyone can be an anesthetist. And anesthetist experience plays a role in what things we are comfortable administering to our patients, especially if we have a sick or fragile patient. Is that the first time to use a new drug? No, actually it's not. Best time to use a new drug is when we have a healthy patient who's relatively young, because what becomes of our vigilance when we have something new that's happening? It becomes hyper. We're aware of things in our brain that our brain usually turns off ahead with things that we're used to. So all of a sudden we go, oh, do they usually have an increase in heart rate? Do they usually breathe that fast? Do they usually look the way that they do to us? And your brain is asking all these questions because it's a new situation, because you're using a new drug. Things that we turn off because they're routine for us, our brain doesn't notice. And so we become hypervigilant. And that's part of the anxiety when trying to use something new. So my suggestion is, if we have something new come to our practice, a new drug, a new piece of equipment that we're just learning how to use it in our younger, healthier patients first. Use it 10 times, use it 15 times, use it 20 times until you're comfortable with it, and then expand it into your fragile patients. So how do we scale drug doses? We go, okay, we've picked our drugs. We've picked our drugs based on all the things that we've talked about. You go, I'm going to use this drug and this other drug. Now, do we use them at the usual dose, or do we lower the doses because our patient is aged or because our patient has multiple comorbid conditions? There's no firm guidelines really on how much to scale back based on physiologic fragility from comorbidities. There is some scaling information for aging, but just know that if you have an old, fragile, sick patient, you should be using very low drug doses. They deserve complete care. They deserve a multiple drug protocol, but we just are reducing the doses of all of those drugs to be able to provide the best anesthesia care we can without inadvertently overdosing them.
I hope you enjoyed that episode with Dr. Lukasik. There is a link and a promo code attached to this podcast that will allow you to get a large discount on her course and also any of our dentistry courses. We'll see you next week.